So, as per my topic, testosterone and male sexual dysfunction. So, if you see, sexual dysfunction affects millions of men. It's like an iceberg disease nowadays. What we see, almost 10 times more men is what they're suffering from. Low libido, erectile dysfunction is very common, and hormonal balance plays a very important role. So, I'll be speaking over these topics only: low testosterone, low libido, erectile dysfunction, and all those things. So we need to first understand, what testosterone really means for our body. So it's a key male hormone which is mainly produced in the testicle. So like vital function, it affects libido, erections, and energy. I mean, to energy means in general, the whole day energy, the tiredness, what we feel at the end of the day is mainly because of the diurnal variation of the testosterone hormone. Natural decline of this hormone is seen 1% yearly. It decreases after the age of 30. So testosterone statistics, overall 30% of men, a number who is having low testosterone levels, 30% who are overweight will have testosterone deficiency. 38% of men above 40 years old have testosterone deficiency. 24% of men who have diabetes also affects from testosterone deficiency. And there is 1% decrease in testosterone every year after the age of 30 years. So this is in general about testosterone. So from this, we can make out, from the whole population of the world, how much men, the population will be suffering from testosterone deficiency. But it's like I have already told, it's an iceberg disease. Iceberg disease means the tip, what we see really in our clinics, but the disease is much more broader than what we really treat. Low testosterone and erectile dysfunction, 2.1% under 40 men with hypogonadism, 50% over 80 men with hypogonadism, and 20 to 30% erectile dysfunction and low testosterone level men have ED because of low testosterone levels. So beyond erectile dysfunction, the low testosterone also impacts on sexual function like reduced libido. Definitely decreased sexual desire plays a very important role. Fewer erections, mainly the morning erections, also the spontaneous erection, and the orgasmic issue, the reduced intensity of orgasm. So low testosterone level affects all these things. And as we see, the lifestyle and all is affecting the low testosterone level a lot. So I'll be coming to that point. Key causes of low testosterone. First, aging, as I've already discussed, after the age of 30, every yearly the testosterone level decreases by 1%. Obesity, the BMI increases, the reduced testosterone levels. Chronic illness like diabetes, kidney diseases, liver diseases, medications like opioids, glucosteroids, primary hypogonadism like testicular failure, and secondary hypogonadism like pituitary or hypothalamic issues. As we can see, the men in between nowadays, because of the work pressure, because of improper sleep, because of the junk food what we eat, and because of a sedentary lifestyle, we see more of people coming in with this stature in our clinics. So how we diagnosed? So mainly we prefer the morning blood sample between 7 to 11 as told by Dr. Sashidhar. We consider low testosterone level when it is below 300 nanogram per deciliter. Free testosterone level has to be measured when the level of testosterone what we see are not matching with the clinical symptoms. Comprehensive review, we should also look into the history of the patient, his occupation, his dietary habits, his sleep cycle, his stress levels, both social and professional, and also whether he is suffering from other diseases like diabetes, chronic kidney diseases, or metabolic syndromes. The other issues like cardiovascular issues or neurological problems should also be ruled out. Why? Because this helps us in diagnosing it and also while treating the patient. Treatment approaches, as we have discussed, testosterone replacement therapy should be on our list only when the patient who has come with ED is only been treated for ED and not infertility, right? So testosterone replacement therapy should be considered in form of gels, in form of injections, patches, and pellet. So what we see that libido improvement with testosterone replacement therapy, the libido improves in 70 to 80% of men. And I've seen that once we give the injection of testosterone, mostly after 10 days, the libido improves, the morning erection improves, and also the well-being of the patient improves. Combined therapies are always preferred. Combining a PD5 inhibitors along with a testosterone replacement therapy is definitely gives very quick results and also is more satisfying for the patient. Lifestyle changes is at the top of the list where we should consider the weight loss, we should consider proper exercise, a healthy diet, a good sleep, and also a proper balance of social and professional life. So the testosterone replacement therapy delivery methods, like if we consider for injection, testosterone cypionate is administered. We normally follow the standard protocol where we give a stat dose. Then after 6 weeks, I call the patient again, give the second dose, and then depending upon the requirement, 3 monthly or 6 monthly. On daily basis, if the patient wants to take, he can take topical gels and also he can take pills. The only problem with topical gels are that there may be exposure to the opposite partner or to the children. So they have to be very specific about the use of gels. Normally, when old age patients who cannot go with the testosterone injections, if they ask for gels, I normally give them and I explain them it should be applied over the shoulder because these areas are very less approached by children. Patches can also be used, like they can put a patch which comes over a period of like weekly. It also comes for 15 days. But these patches, I don't think so, are giving much more better response clinically as per my clinical practice. Oral medications, tablets has to be taken daily, maybe BD dose, but the only gastric acidity, the acidity of the gastric juice, which destroys most of the testosterone and very less bioavailable testosterone, is remain at the end of oral medication. Implantable pellets, definitely it's a good technique. It's almost same like what we give injection, but it's like a pellet which has been inserted within the lipids in the body, which gives a slow release of the testosterone gradually. I used implantable pellets lot within the females who have low libido because in females very slow release of testosterone definitely gives a very good response, not only in libido, but also in the orgasmic pleasure. So conclusion, we should have a very holistic approach. We should find out why we are treating, for what we are treating, what are the factors which has lead to low testosterone level. Also, the age of the patient whom we are treating is also important. We should also know whether we are treating only erectile dysfunction or whether we are also treating infertility along with it. So our approach should be depending upon the need of the patient and not just replacement of testosterone. But when I see a age of the patient having beyond 45 years or 50 years, who are only looking for erections, we definitely replace the testosterone in form of injections or pellets. I don't prefer gels or the oral medication. Accurate diagnosis is very important. Whenever we find a patient where the symptoms of the patient are not going along with the level of testosterone, what is showing in the clinically reports, we should also go for a free testosterone level, or also we should check into SBHG as well as estradiol levels, because the ratio of testosterone and estradiol level plays a very important role in clinical improvement of testosterone replacement therapy. Testosterone replacement therapy benefits should be seen, as I've discussed. When we give injections, we normally see after 10 days, there is improvement in libido, there is improvement in erections, there is improvement into the well-being of the patient. And whenever possible, we should also educate the patient regarding the side effects of testosterone therapy. Like whenever I start a therapy for an age of 45 years or 50 years of age, I always make a point to do a serum PSA, and annually or every 3 yearly, I do the serum PSA level, because giving testosterone to this age group can sometimes lead to prostatic cancer also. So actionable next step, we should, as I have discussed, recognizing the symptoms are very important. Diagnosing the cause is very important, and giving a proper medical advice by consultant urologist and endocrinologist is very important. So we should discuss the treatment, and as per the requirement of the patient, we should give the treatment. Nowadays, along with the chemical formulations, what we have, there are a lot of nutraceuticals which are used as testosterone boosters. These testosterone boosters definitely is not going to give you a jump in testosterone within 10 days. But this kind of nutraceuticals are mainly used in maintenance therapy. Suppose the patient is on testosterone injections, After some time, we can maintain this patient. Once he has picked up to a certain level of testosterone, we can use such nutraceuticals to maintain them. There are nutraceutical supplements widely used. The direct increase in testosterone level or suppression of the decrease in testosterone production due to testicular toxicity. Foods or supplement which raises the testosterone production in three ways. It regulates the LH level, the hormones which is required for the stimulation of testosterone production within the testicles, regulating the testosterone synthetase in the testicle, and regulating the testosterone degrading enzymes. So what takeaway in a very simple way, whenever I see a patient having symptoms related to testosterone deficiency, like low libido, decreased hardness of erections, tiredness, short memory loss, I definitely evaluate the patient, and then depending upon the age and requirement, I will choose the therapy. That is how I choose my testosterone replacement therapy for sexual dysfunction.